Yeah, so like 1 minute, and then we got it.
She said,
Oh, we did the same
back
thing.
in seconds.
Well, like in seconds.
So, I mean, maybe, I don't know if there's just like,
If they try to go too far ahead too fast, like keep them where they need to be. It needs to go not a breather, not invasive, intubation.
trust me.
We're ready.
So he said my name. No way.
I heard Brett, I was like, whoa, what's going on?
Well, as puzzled as you.
Yo, I'm puzzled by escape rooms. Like I just couldn't. I
They're
can't
fun.
follow.
They're a lot of fun.
I just don't get it.
I don't like the time limit though.
Everything.
So like
Everything
the
you can think of the
one that you guys did last, that one,
Not
I
a
think
bit of
more
time.
like the
Yeah.
traditional.
Point
Nice.
5.
Rapid response, ICU. Rapid response, ICU.
Oh, you set the alarm off again.
I thought I still had like a foot of beef jerky stuck between my teeth right now, but let's get her done.
I wasn't prepared for it at the time, so definitely kind of surprised us a little bit.
I knew that was coming for some reason. I was like, you know what, it's like midnight, we're like almost crashing out. So I feel like this is where they were gonna do the plot twist.
Unfortunately, that break, not so much of a break, right? So also, as you get out there and start working and doing shifts, you will realize that that's very much like real life. And you're ready to sit down, you take that break, that's when something happens.
This is typical. This is how it happens. Since I do work in the medical field as well already, that happens a lot, especially when you go to lunch. As soon as you sit down, something happens. So I'm always ready for whatever happens.
So, what's going on now is there's a patient in ICU, and they have just had a rapid response called on them. Y'all's job is to save this patient. The name of this challenge is the last pulse. Here's how this is going to work. This is a team competition. All 6 of you working together. You're going to be split up in pairs of 2. And we're gonna play the classic game of telephone. I know what that is.
so one person something.
That's exactly right. Devin and Kevin, y'all are going in first.
Okay.
Followed by Sarah and Eric. Followed by Danny and Brandon. You will be asked to request information, gather information, and then make a clinical decision. What do you want to do? Okay? So it's up to y'all to decide what you want to do. At that point, you will be tagged out. So when you've completed your mission, you will be sent back out, and you will be telling Sarah and Eric what you just found out. Y'all will go in, you'll have to answer questions from the judges, and then make a clinical decision. I haven't given y'all any clues to anything tonight. I'm about to give you a clue right here. Okay, this is the one clue I will help y'all with throughout the whole night. If at any point a code blue is called, everybody should respond. So 2 at a time, but if at any point you hear code blue and you're out here, you should enter the room. Here's the most important part of the clue. Work together as a team. The key is communication. The key is identifying key roles. Okay? Not everybody can be doing the same thing. Talk to each other. ACLS algorithm in the pre-work. Hopefully you find it helpful.
Hi.
Hello, judges.
You're looking at Mr. Schiff. Mr. Schiff is a 59-year-old who just returned from PACU post-cholecystectomy. He is in mild respiratory distress on a nasal cannula at 4 liters per minute. SpO2 is 82%. Respiratory rate is 30 with shallow. The patient is awake and alert and complaining of sharp chest pain and difficulty breathing. What is your recommendation?
He's at 82%. He's on
He's having sharp pain.
Sharp chest pain and difficulty breathing.
Okay. So we would first assess briefly.
Respiratory rate is 30 and his breathing is shallow.
You definitely, you could probably request you for a nominal breather straight away. I would think a nominal breather.
Then do that.
If we pick nominal.
Good.
Need to stop.
While you do that, do you have any other recommendations?
As we're working on getting this patient's oxygen up, we could probably have another person getting this intubation supplies ready just to be safe.
Yeah.
Because you don't know what's going to happen if the patient's are 82%. I think I'm jumping the gun too fast, so.
I definitely agree. If he continues to descend, then we'll be ready to escalate to the next step.
But we'll see what his oxygen is after the non-breather. So do we have that information after we increase the oxygen?
Would you like to determine that?
SpO2 or an ABG?
He was okay.
It's ordered.
Oh, okay.
Okay.
So we do
Fantastic.
the ABG, poke. Oh, we just need the result.
Now it's at the lab.
Y'all are good. Tag in the next team.
Okay.
To Sam oxygen. Yeah.
Reset.
Resetting at SpO2 82. So we put him on a nominal breather, which is an ABG order. Patients having sharp pain in the chest, resting breathing. Yeah. So we put him on a nominal breather. So now do you want the ABG?
Do you see a COPD patient?
We didn't get that. So 82 ABG order. Yeah. So we
Yeah.
So you need to get an ABG. That way you can see what his oxygen is down.
As well as that receipt too. Okay. Anything else?
Awesome.
Ready, break.
Go in.
So what do you know about the patient?
Set is
SpO2 of 82%. The patient is currently coming, or was admitted for a shortness of breath. Did you have chest pains?
Yes, chest pains.
With chest pains with personal breathing and given order for an ABG.
Okay, the patient is now on a non-remittent. He remains in mild respiratory distress and is now lethargic, so it remains appropriate when aroused. ABG results just arrived. pH is 732, CO2 is 54, and PaO2 is 62. Bicarbonate is 25, and SaO2 is 80. What is your recommendation?
This patient is in ventilation failure as well as oxygenation. So depending on the patient's status, I would consider moving to a non-invasive ventilation like a BiPAP to blow off some of that CO2 depending and rate and everything would be set based on the patient and in the ABG. Okay, I would also, for this patient in particular, I would make sure that I have an intubation tray ready because if he is lethargic, we could easily lose that away. I'm gonna assume he's a medium. And then I would instruct this patient, I know it's not comfortable, but please do not take it off. I know you're gonna take it off. And I can't restrain you, but please don't take it off. And then when they do take it off, I will re-educate them on why they should not take it off. There you go, friend. And then I would check my leak. Got a little head.
And what about the appropriate settings?
The initial settings would probably be 12 over 5. Or 10 over 5.
Rate is 10 over 5.
You want to start with 10 over 5?
Yeah, 10 over
Sure.
5.
We'll do 10 over 5.
Fantastic. Y'all can tag in the next group.
Thank you so much.
Thank you.
What's the couch for this?
Patient is in uncompensated respiratory acidosis. He was in moderate hypoxemia. Uncompensated respiratory acidosis with moderate hypoxemia. We decided to move the patient to non-invasive ventilation because his sats were selective low. So he currently has a nasal and we currently have him on the setting up and over. Cool.
Okay.
Ready, break.
What do you know about the patient?
So they are currently in uncompensated respiratory acidosis with moderate hypoxemia, and their saturation still wasn't doing the greatest, so they got put on BiPAP at
10/5.
10/5.
The patient is now barely responsive with a GCS of 8. They are breathing rapidly but ineffectively. Their latest blood gas reveals the following: a pH of 7.18, a PaCO2 of 72, PaO2 of 55, bicarb of 28, and an SaO2 of 83%. What is your recommendations?
I think intubation because of the pH immediately.
So the pH and the CO2 is still elevated, and if they're on the BiPAP and it has to keep that themselves, that's the only option to keep that low to get correct.
Yeah, I agree. Intubate?
Is there any other information you would like to know?
Is the patient male or female? So if we're going to intubate, we need to figure out tidal volumes, like all that kind of stuff, right?
Yeah. So do we have the weight of the person, or the ideal body weight, or height, or any?
Ideal body weight.
Doctor's not ready for that yet.
Okay.
What if doctor's not ready to figure out bed settings, and where do we want to set up for airway?
Level of consciousness dropping, we probably need to intervene, right?
So like
busy.
OPA? Like
They would tolerate it potentially, but
establish
start ventilating them, CO2's high, level of consciousness low.
If you feel that you have all the information, you can go back and gather your equipment.
We received a little bit of info about how the patient was doing. We were able to go back into the room, and we ultimately were able to decide that the patient needed to be intubated due to their decreasing status.
yeah, that patient is on BiPAP and we'll set up for intubation.
Yeah, I have this hooked up to 100% modular. What size baby you want?
The patient becomes unresponsive and pulseless just before intubation. The monitor flatlines. What is your recommendation?
Code blue.
Code blue, ICU. Code blue, ICU.
You don't have a rhythm while chest compressions are Okay, so we have a male patient. Do I have an ET tube size 8?
Yeah.
Go ahead and get
Slow down and compression.
Slow down. You can sing, that's okay.
30 seconds.
Do I have someone lined up for the next step?
Yes. Yes.
Stylet. Did you check the house?
Keeping the time, keep on going. Make sure you bag every 6 seconds in.
My job was on chest compression, rotation with Kevin. I thought we did really well on keeping the pace with that. Sarah did really well with directions, what to do next. Also Devin with the timekeeping was very helpful. Danny was on the airway. I thought everyone did really well. Brandon was getting what we needed to do with the intubation and everything.
Almost time for pulse check, 30 seconds.
Where's she going?
I did compression guard, so I wasn't worried. I'm chilling with my compressions, and me and my compression buddy, we're taking and swapping, keeping our energy up.
Brandon, you're doing drugs. Danny, airway.
Definitely was comfortable with bagging and airway. And I was, again, super impressed with Sarah, super impressed with Devin. I'm excited to get through other classes that I haven't got through in my program yet because there's so much that I don't know. So I felt good in my role.
Sarah, you're doing the tube. All right, pulse check.
Hold for a pulse check.
Any pulse?
Do I have a rhythm? Your patient's sleep and don't pulse.
All right, Eric, slow compressions. Slow.
All right, so we're just gonna start with Epi. That's the rhythm. All right, so after this one, what we're gonna do is we're gonna, once we finish our second round for the 5 cycles, we're gonna pause for a pulse check. Okay, and then we're gonna administer Epi.
I
I think my biggest fear always in those situations is that although I know the ACLS protocol and I know how to run a code in loose terms, in terms of like a mock code, I feel like this insurmountable amount of guilt. And like, well, I want you guys to be the leaders too. And like, I don't want to say I'm the leader because all of you deserve a chance to shine.
All right, 4 minutes. Let's check out pulse check.
All right, pulse check.
Any pulse?
No pulse.
No pulse.
Still asystole? Asystole. All right, go ahead and resume compressions.
Good. Keep the mask. Keep the
All right,
mask.
mask up. Back up. All right, next pulse check, we are either going to give one of the NBCs, Narcan, sodium bicarb, or calcium. Say out loud what you're doing.
You gotta get the bag mask set up. Set up the CO2 on top of it.
Like Sarah, she took up the role, like make sure you say your medicine, make sure you do this, make sure you're announcing what you're doing so we can all know what's happening. So she did good at that part too.
Any pulse?
Fine, VFib. VFib? All right, that means we're gonna defibrillate, so 360, clear. Pulse check, rhythm check.
Something that.
All right, resume compressions.
Brandon.
We get bilateral.
Did we get gold?
A
3
little
golds?
faster on the chest compressions, please. Yes.
3 golds? Okay, so we're in.
Shout out to Devin, shout out to Sarah. I'm very thankful of them because the way they took charge of that challenge, but they did amazing guiding us through everything. We listened, we observed, we all did our part to the best of our abilities. So yeah, I loved it. I think it was great.
30 seconds. Eric, you good?
Good.
Pulse check.
Pulse check. VFib.
All right, prepare for shot. Clear.
All right, clear.
Okay.
What's our rhythm?
How's the rhythm?
Do you check the rhythm after you shot?
Just go back on.
All compression.
So I'll shot. Go.
300 millimeter I'm given.
Okay, 9. Push my feet. Is that you given?
1 milligram in 10 milliliters of solution given at that beat.
Go down on compressions.
My favorite song to do in my head during a code is Pink Pony Club because I'm really sick and tired of So Pink Pony Club has the perfect tempo and that loud a whole moon, so it just feels right. And I feel like you're always like in a super dark place during a code, like if you're a normal human being where it's like this sucks. And I've never been sad listening to Pink Pony Club, so.
Actually, once she's stagnant, you can get the vent ready so we can put this patient in the vent. Okay. Pulse check.
Pulse check, that's my rhythm.
You have a heart rate of 72.
Okay.
Science rhythm.
Science rhythm. Okay, perfect. We just keep bagging. We got a heart rate. Now it's getting the vent. We're going to get the patient set up on some basic vitals.
The ventilator is here and set up and ready to be used.
Good job, guys. You guys killed it.
Not bad.
Family member just arrived and I'd like to know what happened.
So let me just let the family know simple terms.
We went ahead and put them on machines to debrief for them for a little bit, give their lungs a little bit of a break while we get the main problem figured out.
Yes, because their heart is stopped, and so when the heart stopped, we had to perform compressions. During that time, we did, break some ribs because we wanted to be sure the key. Again, I explained to them so that way when they look at them, they're like, "Oh, I saw these bruises."
I think I'm definitely ready for that next coach, so watch out, I'm coming.
Congratulations, contestants. Very nice job. We're gonna give you a real break this time. So grab some pizza, grab some drink. We'll see you back here soon. Okay.
So what should I say? I thought Devin did really well about, and you're doing this, you're doing this, you're considering this, and I've been very calm about it.
Yeah, I wrote Devin's name down too for being found cool quieted.
And really, he did such a nice job doing chest compression feedback. How is the team like?
That's what I asked him to try to establish.
I mean, I felt like there was kind of two.
Yes.
Yeah.
And that was the problem. And I finally went to one, then I went to the other going like, you guys need to set roles because Devin was calling it the way I saw it.
Seemed to be that.
It would have been
the team.
And no one asked for any updated vital signs in between his chat. I was trying to get that
all the way actually, and I think they did a nice job of handing off.
Yeah, good man.
But the stories weren't the same.
They were
So they did not get the story. Like they didn't realize he was supposed to telephone the second time. Yeah, the telephone.
It is.
And so was the only thing that's like
And I told them a heart rate, but they didn't ask for a pulse. I'm like, whoa. Yeah, that's right.
Good.
They were definitely there.
And I have to realize that, most of them are first year students.
Yes.
Yeah. Devin's the only exception.
Graduates in August, so
Yeah, and so you kind of have to understand where they are.
Welcome back, contestants. Hopefully you had somewhat of a decent break there. That was a stressful little situation we had there a minute ago, and the judges have some feedback for you. So we're going to start with Kathy.
First of all, great job, guys. Some positives we're going to give you. Really well with some closed loop communication with each other, right? Even professionally reminding each other to make sure that we do closed loop communication. It's important to be able to maintain that professionalism, right? Not just call someone out for not doing something, okay? Also, good feedback for each other too. Devin, you calm, cool, collected. You gave good feedback regarding good chest compressions and all of that. So nice job.
Dana, did you want to add anything on top of that?
Yeah, I'm at the other side. Well, I think areas of opportunity, because we all have them, right? The clear role identification, I think, was the thing that most stood out to me. So who was the team leader?
Honestly, I'm going to be designated a team leader. I just kind of roll with it, and then as I was just sitting back, I was watching, so I was like,
What do you think the challenge of not identifying a team leader might be? Not knowing who's the shirt we call. Exactly. That's a great point. So make sure that's the first person you should be identifying, right? Because then they're assigning the other roles. So just keep that in mind. It'll help with the flow.
I think as a team, we did great. The only thing, that we did have feedback about was nobody really initiated a role. We just kind of just did our thing. We didn't really say oh, you're this person or you're this person. We just kind of just did it. And I think by establishing a role in the future, that will help us become better and help out the patient a lot.
Other things I would just suggest is remember to always check the pulse, right? When you're told that the rhythm has returned and there's a heart rate on the monitor, it doesn't always mean they have an actual pulse, right? They could be in PEA, so keep that in mind.
Thank you. Remember what I told you?
Could I give a teammate shout out?
Absolutely.
Really shout out Devin, because when we were giving report out to the family, I think I've said it to you a couple of times, there cannot be love for medicine without love for humanity. And the fact that the way you worded certain things when you were explaining things back to the patient, in my head, yeah, all patients should know that there's, families are going to know if I'm doing CPR, I'm breaking ribs. But you thought to mention that, hey, please be aware, when you see them, they're not going to look like you always see them. They're going to have broken ribs. And I thought that really shows to your bedside manner. And I was really impressed by that. When I get in the field, I want to say that. So I just wanted to give you kudos. That was really cool to see you bring up. I think it's really important that it's, yes, the patient, but also their families. So I thought that was really awesome.
Absolutely. Thank you, sir, for that. Remember what I told you today before the judges ever were even here? First time we met in this room, you're here to learn and grow. These individuals, they didn't give up their 24 hours today to just come up here and say these words. They mean it. So if you'll listen to them, I promise you'll leave here an extremely strong respiratory therapist. Okay? Promise you. Learning and growing. Have it right now. Now, judges have been very, very nice because it was a team effort. Okay? For this successful attempt during the last pulse, everybody is receiving 50 bonus points. And because I get to make the rules, from what I heard from the judges, backed up by Sarah's words just now, damn it, I'm giving you another 25. Alrighty, I'm extremely proud of y'all. We're going to lower the temperature here just a little bit because one of the things I wanted y'all to get out of this was not just come here and compete, and then we end and we all fly back home and we're done and you're like, wait, I want these amazing professionals that I didn't get to pick their brains. I didn't really get to learn from, right? So what we're going to do now is a very casual roundtable discussion, okay? It's a roundtable without a table, okay?
You can't be an expert on day 2, right? That's ludicrous. But I do appreciate that sometimes you feel like you need to speak up, right?
A lot of things that we did in the exercises, a lot of times is putting that puzzle together. And sometimes it can be misleading. Like I just led you guys one time on the pleural effusion versus a pneumothorax because I only got half the information and never really looked at the chest x-ray. Other than recognizing that it was flipped backwards, and those types of things. And so, it's got to do your homework at times. And I think you won't lose credibility if you do that.
I knew it was pleural effusion, but I didn't speak up at that time to say it. I was just like, we had that 1 minute, so I was like, oh, can we do this? And then I heard atelectasis, I was like, can we do atelectasis? But in my head, I was like, no, it's pleural effusion. That had my study partner in my head going, pleural effusion. So that's what was hitting me when I was thinking about it, but I didn't speak up, and I should have spoke up at that time.
I'll often tell new grads that you'll be competent before you're confident. But I also tell new grads that I expect you to be anxious and have lots of questions. And quite frankly, if you don't, if you're overconfident, I'm more worried about that employee than I am the one that asks good questions. Mm-hmm. But to ask questions, to seek growth, that's the mark of someone that's going to be a remarkable therapist.
You have the drive to do the things too. Like you're not just standing back and letting someone else do it, but let me try, or can you show me how to do this so I know what to do next time.
They kind of hear this concept sometimes. It's like, look, this new grad, when they come out, I need to know that they can do the job like I can, and they've been in the field for 20 years. And when you hear that, if you hear that, just know that that statement says more about that 20-year vet than it does the new grad. It's unreasonable, like Dana said, to come out of school and be able to perform like somebody 10, 15, 20, sometimes even 5 years in. It's just not feasible. Kevin, do you have a question? And you can kick it to any judge that you want to.
My overall goal with this career is to be kind of versatile questions, to be kind of like a subject matter expert, right? So outside of like what we're learning in school, what would you guys be advise me that as a new grad and somebody wants to excel and be that person that can be that reliable RT?
I think one is you have to be thirsty.
Yeah.
Like you have to seek out your opportunities, and we talk about like do what you're passionate about, and the opportunities that will like just come your way. It's pretty incredible. A lot of the times it's about just doing. Ray and I were talking about this in the way here. Is doing the things that nobody else wants to do. Seek out people and resources and mentors, whether they're formal or informal, to help guide you and give you additional tools so that you can achieve your goals. And you're surrounded by a lot of great people.
Yeah.
We're all friends now.
Sarah, you have a question for somebody?
What, in your opinion, separates the knob turners from an exceptional RT?
You're questioning the providers professionally. Why are we doing this? What's your indication? What's the reasoning? What's your goal for this patient, right? Versus someone saying, okay, I'm just gonna do whatever they tell me to do. The other thing is, and this happens a lot sometimes, you get an order for something, and that patient doesn't need that. Did you even go look at that patient to see if they really need it? Don't just assume that patient doesn't need that treatment or whatever it is. Go look at the patient, get up, get out of the office, go look at the patient, evaluate it, and then go back and say, I agree, I disagree.
I think if you let evidence guide you and better patient outcomes, knowing that you are the difference between many therapists, I think, want to always work in the ICU when you first graduate. So having critical care skills on your floors, doing therapies that they need versus not worrying about what they don't need. Because we get hung up on them not needing the bronchodilate, but what do they need? Because we know that the best evidence for them having good outcomes is walking. So if they're not walking, they need something from us. And offer that evidence to them.
Like, what are you going to be able to talk to a patient when you're in the ICU and kind of like see what they need at home? Like even just toweling off after a shower. Like if they're getting short breath, like, well, give them some tips. Or walking from the bedroom to the bathroom.
talk to your patients, see what they actually need for their hospital stay and their life at home too. So look at that.
I think just by asking the question, it separates them.
Sure.
Because the first one's not even thinking about the other ones. True. Brandon, we're gonna go to you.
So at least for like where my program track is at, we're kind of in a big transition from receiving all of the knowledge most of the knowledge that we need for continuing the program into transitioning and using it actually in the field and at the hospital. So other than just like going to clinicals, do you have any like good strategies on the best way to taking that knowledge from here and then being able to apply it right in at the bedside?
I'll take that one. Progress, not perfection. Being able to mature enough to say, Eric, that didn't go so well, so let's do better next time. Not saying I need to get out of the field because I'm crazy, and things like that. Just keep pushing it. And then when you get into clinicals, it's now you're taking that knowledge that you have here and applying it here and seeing the progression of learning. You should not be an expert. If someone is checking you off and giving you 5s out of a scale of 5, every time you do a procedure, they're not helping you. It never stop learning. When I worked at Harvard in Boston, one of the things that a lot of the Harvard professors do is they wear short jackets. And so short jackets, obviously, as you guys know, are meant for medical students. And so I'm like, why is this attending wearing a short jacket? And what he wanted to visualize and express is that I'm always a medical student. No matter how long I've been practicing and how much of an expert I am, I'm still a medical student.
I would say too, just to add to that, is always be willing to ask questions. I don't know everything. I don't. And I'll be the first to admit that I don't know everything in that stuff. And I'll ask my colleagues now that were former grads, saying, can you help me with this? Because I don't know what I'm doing.
One of the most common things I see is that bedside respiratory therapists, when they're serving as preceptors, are hesitant to give constructive feedback. It's hard to give hard feedback. What could I have done better today? And just that simple question sometimes opens the door for true, honest feedback that you might not honestly get. And the truth is, you should have something that you could have done better today. And I think that really makes a difference.
It's vulnerable. It's it's a lot of vulnerability. But when you take it and you realize that it's just one step in front of the other, and you're constantly getting bigger and better, and there's a lot of people around you that can help you get there.
What are some non-obvious blind spots that maybe you all have already seen? Like that quick assessment of us, of like, okay, I can see where this person is really gonna shine and where this person is really going to like fumble.
It's not just you're going to work, you're getting a paycheck. I think you have to have a passion for something. And of course you're gonna have a little bit of burnout here and there. But when you think about like what you're doing and how you are advancing yourself, when I was working in the hospital, like I would go in with a bright smile on my face, and I would have a good day. Instead of going to work, you're making a difference. You're not going to work and making a difference.
For me, it's resist comfort. That's where I found career satisfaction. Stepping outside of my comfort zone, stepping outside of what I thought I was so good at, and go, I want to be challenged again.
Yeah. It's called a blind spot for a reason.
Yeah.
They're all non-obvious, right? To you. Yeah. They're real obvious to the people around
That's
you.
what I mean.
That's the trick. And so I think creating those relationships where you can say, do I have the stuff in the teeth? Right? And really ask that question and have people that you can trust and rely upon, but to create that space to say, I want to be better. Help me.
You build these relationships with people across the nation, like what we have here. It's when you have those weaknesses and other people start to find them and see them, then we have conversations and they find ways to come out and help you grow.
Be that lone nerd, we say, like, I'm on socks for us guys, that we're lone nerds, things like that. Just having fun with it. Readers are leaders. I always will say that, and kind of keep pushing that. Is that it's something that enjoy it. You'll never have to work another day in your life if you really found the job that you enjoy and the hard science of it and things like that.
I'm a fan of advanced practice respiratory therapy as a degree, but I am a bigger fan of advancing your practice as an RT.
Okay, I totally get that. I totally get that.
And at some point, you find out where you are.
When do you feel confident in yourself as a student transitioning, passing the boards, and then practicing?
Depends on the day, the time. Sometimes I'm on it, I'm good, I'm ready. Other days I'm like, ooh, what was I thinking? Can you help me troubleshoot this? I don't know what this means. The confidence can come and go depending on what it is. It changes. I mean, there's some things I'm really good at, right? Maybe ABG interpretation, but then other times I'm like, no, I don't know. So I would say that it depends.
But when you first start, it's a work in progress, and we warn people about it because transition to clinical practice is a huge transition, and so that's why we push you, and that's why the NBRC works really hard to develop a competency exam to get that minimum level. And that is truly the minimum level.
That's right.
Where you want to be is at the top of the licensure. That's where we all want to be. Our patients deserve experts.
Always strive for something better and strive for something more to build yourself up from that, and then that's how you build that confidence.
Confidence isn't the end, because it will come. You will find yourself one day where you go and you're like, oh my gosh, I'm not nervous talking in this morning. I feel confident today. It doesn't mean it's the end of the road. There's still so much more to go. When you find yourself confident, that's when you find the next level that makes you not confident, but puts you back in that nervous state again. Because I promise you, one day you'll miss feeling nervous.
I want to ask Melissa and maybe even students, how often do you get them a month later, 2 months later, 3 months later, being honest and saying, I'm struggling in something? Do you actually get that feedback, or do you have to break through?
My team in particular, we're a lot more vocal about having those conversations. One of the most passionate discussions we had in a leadership meeting was about how acute care was so full of new grads that it would be a harm and a danger to our patients, that we needed to diversify how we were orienting new grads, but we needed to align them with the right preceptors. So I would say it's, as leaders, regardless of whether you have a formal role or not, it's all of our responsibilities to pour into anyone. I think new grads most certainly, but anybody that comes into the organization, regardless of where they're at in their career.
I do want to give Dana 60 seconds, if you will, a plug for the AERC Emerging Leaders Program, because I think you've got some in the room here.
The Emerging Leader Program is a relatively new program that we have, and it's designed for folks who are looking to take that next step, right? That are either informal or formal leaders looking to grow and advance.
Phenomenal discussion. Thank you all very much. We're going to step out now. We got to get the room reset here. So contestants, real quick, freshen up. Judges, real quick, freshen up if you need to. And then we're right back in here to get to the next challenge. Welcome back, contestants. Welcome to round 5. It is now after 2 a.m. and we should probably check in with our judges, right? Judges, how we feeling? So Teresa looks ecstatic. Kat?
I'm great.
Great. Melissa? Ready to roll?
Here.
All right, I'm actually got to get in here in a few minutes.
Okay.
All right, so we're going to kick off round 5. We're going to keep it a little lighthearted with this next challenge. This is Med Supply Fashion Show. Okay, so in this challenge, you're going to be split up into pairs of 2. You will be assigned your own space. You will have 20 minutes using standard PPE, as well as any of the equipment seen on the tables, the low table and the high table just outside the ICU, to create a look using medical supply and a couple of other fun stuff. The kicker is that you'll have 20 minutes to complete your look, and then your look will be presented. You ready to find out your groups?
Yes.
Yes. Here we go. First, team 1 will be Devin and Danny. Your model that you will be dressing up is Coach Melissa. Your design space is right across the hall in the PICU. Team 2, Kevin and Brandon. Your model is Coach Brian. and you will be in the ED. Finally, our third team, Eric and Sarah, and you will be dressing up our celebrity judge, Danny Evans.
That was not in the fine print.
Your all's design space is at the collaboration table. Are y'all ready to play? Men Supply Fashion Show?
Let's go.
Yeah.
Alrighty, head to your stations. Your 20 minutes starts now.
Baby, you're a shooting star.